Good afternoon, everyone. I am very happy to have you all on the FearlessHer Podcast today. I am delighted that you have joined. This is a global conversation where we speak about women and girls, health, gender, things that impact the lives and limit futures of women and girls. Today, I am very delighted. I'm honored that I have Jennifer Cleall with me on today's podcast. Jennifer, in a few minutes, can you tell us who you are in your own words and what has shaped your narrative and your perspective till date in relation to women and girls?
Great. Hi, everyone. I'm Jennifer Cleall. My current role is I'm the global head of digital transformation for Ferring Pharmaceuticals, which is a pharmaceutical company about mid-size. I have been in pharma a very long time. So my journey started in the U.S. And I worked. I was studied computer science and medicine. So doing computer science. Back in that time, there weren't very many women represented in computer science, and so I do a lot of work with women and girls and getting them into STEM and technology. So my journey kind of started around that, but then also as I've been working and progressing through the pharmaceutical industry, as well as looking at then just how gender is showing up in representation in clinical trials and in our data and how we can learn from that and so on. So I'm a pleasure to be here, and I'm looking forward to the conversation.
Amazing. It already sounds like this conversation is going to be very powerful. So Jennifer, from your perspective, how is gender currently showing up in health data and patient outcomes globally?
Yes, I think it's really interesting, this question, because gender is showing up in outcomes that in ways that aren't immediately obvious, but when you start to look more closely, you start to see the pattern. So, for example, women are around 50% more likely to be misdiagnosed after a heart attack, but it's not because the disease itself is fundamentally different between men and women. It's just about the way that we understand and how we have historically understood the disease, and because it presents differently in women. So it's not been fully reflected in how we've defined and understood things. Mm-hmm. So when you take a step back, there's a historical reason for that. I think in the 70s, the US FDA thought that they were doing women a favor by excluding women of childbearing age from clinical trial, from early stage clinical trials. And that's meant a lot that our foundational then knowledge was built on that early clinical trial data, which excluded women. So we weren't represented. So you could say that it's been based on male data. Yeah. And then in the 90s, that's when there's a National Institutes of Health Revitalization Act that was put in place that made inclusion a requirement. So we've made a lot of progress since then. So we now have more women represented in clinical trials overall. But certainly what I've seen is that inclusion doesn't necessarily automatically translate into understanding. Mm-hmm. So even when women are included, the data isn't always analyzed or reported in a way that helps us fully understand what those differences are between men and women. So in how diseases are present or how treatments work and so on. And so I think the point now is looking at it as we can do that. We have the science and the methodology, and we have all the data. Yeah. But it's really the design studies. We need to look for those differences. So if you analyze the data outcomes by gender, then you can generate that meaningful insight. But it has to be deliberate and intentional from the start when you design that clinical trial.
Amazing. Deliberate and very, very, very in charge of it. So I think what you've just said, Jenny, has drawn my mind to something. And I am looking at the everyday woman, everyday girl who might be listening to us today. That's how these kind of patterns could impact us. And so I want to follow up from that to say that to what extent do you think that the current AI and data system reflect or reinforce existing gendered inequalities?
Yeah, this is a hot topic as well right now with AI. So I think it's important to note that AI is not necessarily creating new bias in the system, but it can scale whatever bias already exists in the system. So AI models are trained on clinical trial data, real world health data, and published literature. All reflects, though, how data was historically generated, a lot of that data. So, like what we just discussed, the foundation didn't fully represent women until later, and then we're not analyzing those differences in a meaningful way. So even though we've made a lot of progress on inclusion, AI systems are still learning from decades of data that carry those gaps. And so the biasness doesn't just disappear, it persists in the foundation. So it all comes back to that idea that inclusion just isn't enough on its own. So you can include women in the data, but if it's not designed to understand how those outcomes differ, like it's like having, we have all this data, we're just not asking the right question of it. So then you don't get the insight. And certainly what I've seen in my work and anybody that works in healthcare, we're looking to move very quickly to apply AI across healthcare, which is really exciting. But it also means we have to be careful. We have to be very intentional because those differences, if we're not really clearly capturing those and understanding them in the data, then the AI systems won't learn from them. And so there's a real risk that we end up building these very advanced, capable systems that are still based on incomplete understanding. And that's where inequalities can be reinforced and then exponentially scaled. So we have an opportunity, though, to do things differently now and apply those learnings, but we have to be very deliberate about how we design, analyze, and validate the data that those systems are built on.
Amazing. Jenny, this is so powerful, but there's something that I think my audience would like to know. How did you first get into this AI and data analysis? How did you get into it? Because it's very interesting and I want to know. I think my audience would want to know as well.
It's like, as I mentioned in my intro, I did computer science and pre-medicine. So I'd like to think, I predicted where all of this was headed, but, probably not the case. I took, was ever a way to say, choose the subjects that you love. I loved healthcare and I loved, technology. And so that's kind of what's led me on this journey. But I think AI is an area that, even when I was in university, I was doing AI and genetic algorithms and looking at ways we can model things in technology and introducing new potential disease variants into this AI model and things. And now it's much more at everybody's fingertips on your mobile phone and so on. So it's always been an interest of mine. And certainly now we're looking at it in my work and other pharma companies are looking at how you scale it and can use it. But back to that, you have to be very deliberate. We want to use it in the right way so that you don't scale systemic problems.
Absolutely. And that is very interesting. So I want us to delve deeper, Jenny. At what point do you think that the gaps that you mentioned earlier begins to shape long-term health outcomes for women?
Yeah, I think the gap exists today. Healthcare systems have largely been designed around what's easy to measure. So we tend to measure counts of things rather than what actually women experience. And so, we talk about capturing clinical outcomes and things, but not necessarily those experience ones. And so when you think about a woman's health journey, they're often more complex. They're less linear. Symptoms can evolve over time. They span multiple systems, and they don't always fit into those neatly predefined clinical pathways. And so by the way our data systems are structured, they tend to be more episodic and standardized as well. So there's a real disconnect between how health is experienced versus how it's actually captured. So a good example of this is like endometriosis that can take 7 to 10 years to get a diagnosis, or even more broadly when you look at something like perimenopause, which is a topic that everybody's talking about today, certainly with women in my age group. But you can experience a wide range of symptoms, from fatigue to anxiety to cognitive changes and so on. And so those aren't always necessarily immediately recognized or even being connected as into one thing. And so the gap then exists at a very practical level. So if you look at how patients then interact with the system, even as something as simple like the e-consult form that we have to fill out to get an appointment with your GP, we're often asked to select from a predefined list of symptoms or describing a single issue. But many women are experiencing multiple things or interconnected things. And so that entry point is where you start to see points of failure where the gaps start to persist. So you don't want to necessarily tick every box and feel like you're overreacting, but if you simplify it, and you could go down a pathway that, it doesn't really reflect what's going on. So it's important to recognize that we have an opportunity to capture meaningful signals about how their health is being experienced. So at the point of entry, we're losing those important signals if you can't select what you need, or you can't fill in the information. And then even when you go to talk to a doctor, there's the reality of limited time. And so you have to prioritize what you say. You also have to feel you're being trusted. If I invest the time telling you all of my stuff, are you going to listen? Are you going to, actually take on board what I'm telling you? And then we're also trusting and have to rely that that healthcare professional is capturing that information meaningfully. So the next time you go back to the GP or the doctor, you might think, well, I'm not going to tell them all that. I told them all that last time because they've got it captured. But if it's not been recorded, then we're missing out on how they're experiencing those conditions and health over time. So, from a data perspective, we're good at capturing clinical events. So diagnoses, treatments, interventions, but we're not very effective at capturing system progression, the context, and just how experiences evolve over time. So we think about moving towards this more data-driven healthcare that we're all talking about at the moment. We risk missing signals that matter most if we're not capturing lived experience properly. So over time, the gap just doesn't stay in the data. It starts to shape behavior and trust as well. So if you have a bad experience, or you're not feeling like you're being captured, you're not being understood, you're going to stop maybe sharing so much insight as well. And once those signals are lost, it's difficult to go put them back in place later.
Powerful. So what I have just captured from that bit that you said is about lived experience. So I think it will resonate with a lot of women watching me today in this conversation, because it resonates with me as well. Whether what we are living or what we are expressing is actually someone actually listening, or is it just the systems doing what is structured to do without considering our lived experience? And Jenny, that was very powerful. Before I let you go, Jenny, there is something that is dear to my heart, and I think the audience would appreciate if you can help us with this. What would a truly equitable, data-driven healthcare system look like for women in practice?
For me, it's about moving from not just including women, right, and considering them in the system, but intentionally, deliberately designing the system around how women actually experience health. So we've made progress on representation, as we've talked about, but the next step for me is really designing for insight. So that means structuring studies, data, and the systems that allows us to capture genuinely understand the differences, not just observe them. So from a data point of view, that would be things like more representative data sets, broadening what we capture, so bringing in real world data, and patient reported outcomes. So patient reported outcomes are those that we would report. I'm feeling stressed today. I'm feeling tired. I'm whatever it might be. So that we're not just seeing isolated clinical events, but we're seeing how health is experienced over time. And then that means analyzing the data differently. So making sure that we're looking at outcomes across gender and across that full patient journey. So anybody knows I talk about the continuum of care, that patient's continuum of care from experiencing symptoms, reporting them, treatment, and so on, that full continuum of care, so that we're looking at those outcomes and how they differ by gender across that as well. So because if we don't analyze those differences, we won't see them, and then we won't design for them. So for me, that's the system itself. So we need to move from something that is episodic to something that's more longitudinal, so that we are capturing, looking at where information is captured meaningfully, it's carried forward and then built on over time, so that you don't have to keep re-explaining your experiences and we don't keep losing those signals. So just remember that we're humans at the center, and we need to be heard and taken seriously. And we want to feel that what we're sharing is valued and used, because without that, the best systems won't capture the right data. So.
Yeah. Amazing. Your last point, very, very powerful for me. We are humans. We want to be heard. And we need to move or shift from it being episodic to longitudinal continuity. This was a very powerful conversation, Jenny. And I want to say that I have learned a lot from this, and I believe my audience have also learned something. How do we get in touch with you? If there's someone who has loved this conversation, wants to know more about your work or what you do, how do we get hold of you, Jenny?
So I publish a newsletter on LinkedIn as well, called the Innovation Continuum, and then a LinkedIn message is great as well. I'm still working through my other social journeys on other topics, but LinkedIn is great.
Great, amazing. So are you happy for me to post your LinkedIn on the video for people who want to have contact with you? Yeah?
Yes.
Great. Jenny, it's been a beautiful conversation with you, and I have appreciated this chat, and I do believe that the audience have appreciated it as well. Do you have any last words before you leave us today?
So many. Well, this has been a great conversation, and I welcome more of these. I hope we are, when anybody I feel in digital or technology or healthcare should be thinking about how do we make sure that health is improved for everyone, and that we're getting, and that we're understanding the gender differences, which is so important. So for me, it's not just a way thinking about how we digitize healthcare, but it's making sure that it's more representative, it's more connected, and ultimately we want to deliver better outcomes for everyone. So thank you for including me in the conversation.
Thank you. And I'm looking forward to better outcomes and further chat. Thank you, Jenny. Have a great afternoon. It was a pleasure to have you on.
Thank you, Rachel.
Thank you.